My name is Priscilla and I'm going to take you through thrombosis and congenital heart disease, which is tetralogy of Fallot that our patient had. So what is thrombosis? Thrombosis is an abnormal formation of a clot composed of blood elements inside a vessel. It develops as a result of disruption in the delicate balance between the procoagulants, anticoagulants, and the fibrinolytic system. So it is affected by the virtuous triad, which is usually consists of stasis, vascular wall injury, and hypercoagulability state. So in the pediatric group, thrombosis occurs mostly before the age of 1 year, mostly in the neonatal period. They say after the neonatal period, the incidence really goes down. And the incidence, as per studies done, shows that it is around 0.07 to 0.14 per 10,000 population. So normal hemostasis is a balance between bleeding and thrombosis. When you have impaired clotting, you get hemorrhage, and when you have an excessive clotting, you get thrombotic complications. So hemostasis is activation of multiple components of the blood clotting system in response to vessel injury to control bleeding. It has 4 major events that occur. That is primary hemostasis, secondary hemostasis, fibrin clot formation and stabilization, and inhibition of the coagulation. So these are the details. So in the initiation phase, we get the formation of small amounts of thrombin, whereby you have tissue factor and activated factor 7 forming the tissue factor complex, and this cleaves small amounts of factor 10 and factor 9 to form small amounts of protein, thrombin. In the second stage, you have the propagation stage. In this stage, you have tenase, which activates factor 10 and activated factor 5 to form the prothrombinase. This is the summary. So on the far end, on the left, is the extrinsic pathway where you have the tissue factor complex, and on this side is the intrinsic pathway where you have the tenase complex, and they all cleave factor 5 and factor 10 to form thrombin, which converts fibrinogen to fibrin, and eventually you get the insoluble fibrin, which is stable. And this is a negative feedback, whereby after you form the fibrin, then the negative feedback will stop the process and the coagulation process will end. So this, on the extrinsic pathway, we use the APTT to test for any deficiency of the clotting factors on the intrinsic pathway, and on the extrinsic, we use the prothrombin time to test for any deficiency of the clotting factors. So eventually that is what happens. So the risk factors for thrombosis would include immobility, use of estrogen-containing hormonal contraceptives, intravenous drug use, pregnancy, the neonatal period. The neonates usually have deficient clotting factors and also the liver enzymes. Then there is a history of recent surgery, is a predisposing factor, obesity, infections, malignancies, and congenital heart disease. So our patient had like three of these predisposing factors to his condition. So we just give you a brief summary of our patient who had congenital heart disease. So in Uganda, we have 8,300 children born annually with congenital heart diseases. 2,000 are severe enough to require cardiac interventions, and the congenital heart diseases that cause the majority of pediatric cardiovascular morbidity in Uganda. The VSDs, according to studies done by Aliko et al., were found to be the commonest at 26.5%, and tetralogy of Fallot is the commonest cyanotic heart diseases. So what is tetralogy of Fallot? Tetralogy of Fallot is one of the cyanotic congenital heart diseases, and the primary defect is an anterior deviation of the infundibular septum, and this leads to 4 components. You have overriding aorta, pulmonary stenosis, ventricular septal defect, and right ventricular hypertrophy. So it's the pulmonary stenosis that will determine the symptoms. If you have severe pulmonary stenosis, then you get a severe right ventricular outflow obstruction. So this is what would usually give the symptoms. The more severe the stenosis, the more the severe cyanosis beginning right from birth. But if the stenosis is mild or is not severe enough, usually you don't even get symptoms of cyanosis. And the VSD is what would allow the mixing of the blood, and that is what, when the blood mixes, that is what gives the cyanosis and persistent hypoxia. So these children with tetralogy of Fallot usually have hypercyanotic spells and have polycythemia, which is a compensatory mechanism to the persistent hypoxic states that they usually have. And so what are the predisposing factors for thrombosis in children with congenital heart disease? One is the type of cardiac defect that they have, the congenital heart disease related complications. Usually they are taken in for surgery. Now, a child who had TOF would have benefited from autopulmonary shunting, I just forgot the name, and the stage of care. So that is usually what would predispose them to developing developing thrombosis. This is just a table showing the summary of the highly likely congenital heart diseases that will give you thrombosis, and cyanotic heart diseases are have the highest predisposition. So why thrombosis in congenital heart diseases? Many of the structural cardiac abnormalities lead to changes in blood flow, and the natural anticoagulant deficiencies due to hepatic hypoperfusion secondary to impaired heart function further contribute to a hypercoagulable state. So for TOF, this child would have benefited from the autopulmonary shunting, the Blalock-Tausing shunt, but the child came in too late when it was already too late to operate. So these are the procedures that would increase the risk, and commonly it's cardiac catheterization and cardiopulmonary bypass. So how do we investigate a child you suspect to have thrombosis? One, you start by doing the baseline investigations. One is the CBC. You look at the hemoglobin level, hematocrit. A hematocrit more than 65% is a high predisposing factor for thrombosis. Platelets and white blood cells, because that will also show you if there is infections. And then coagulation studies, you do prothrombin time, APTT and fibrinogen. Then you also do your liver enzymes, renal function tests and electrolytes, D-dimer levels. D-dimer levels are, when you have no D-dimer levels, it is a specific test that shows there is no thrombosis. And duplex ultrasound is the most sensitive if you have DVT. And then for pulmonary embolism, you do spiral CT, chest CT, and for the brain you do MRI, angiography. Yes.
Thank you very much. Priscilla.
Good afternoon. So, what treatment can we give specifically in our patient? We noted that the patient was on both heparin and warfarin, low molecular weight heparin. But when they developed the episode of bleeding, the warfarin was stopped, and at that point we were not measuring the INR, which is very important, especially when you're taking warfarin. And so currently our patient is on low molecular weight heparin. It acts as an indirect anticoagulant and exerts its anticoagulant effect by combining with antithrombin and inhibiting only the coagulation factors, activated 10 and activated 2. So it's administered subcutaneously, and usually it doesn't require monitoring, but if you must, you can monitor anti-10 activity assays, which are mostly done in our pediatric population in children who have renal issues with a creatinine clearance level of less than 30, and if they are adolescents, if they are pregnant. It has a half-life of 3 to 6 hours, and it's cleared through the renal. That's why its half-life is therefore prolonged in children who have renal problems, and so it should be used cautiously. Some of the side effects are bleeding, because we are anticoagulating, so bleeding is expected. We may get anaphylaxis if a patient has a reaction against it. It may cause osteoporosis, heparin-induced thrombocytopenia, skin reaction, eosinophilia, alopecia, and hypertransaminasemia. So in an event that a patient started bleeding or in anticipation for any major surgery, you can do elective reversal of low molecular weight heparin, and that should be done 12 to 24 hours before the planned procedure. Urgent reversal is not really possible because there's no exact antidote for low molecular weight heparin, unlike unfractionated heparin that has an antidote or protamine. And Warfarin is an oral vitamin K antagonist. It antagonizes clotting factors, all the vitamin K dependent clotting factors that are the 2, 7, 9, and 10, as well as the protein S and protein C. So it inhibits vitamin K and prevents activation of the above factors. It has a half-life of 36 to 42 hours, and in our pediatric population, we usually start it at less than 5 milligrams. However, we must monitor the INR whenever a child is taking Warfarin, at least every 48 hours, because we must ensure that it's kept in the therapeutic ranges. So usually we start it together with low molecular weight heparin and give it together for at least more than 5 days until the INR value is between 2 and 3 for 2 consecutive days when you started it. And then you adjust the daily dose accordingly, and your aim is to have your INR levels within the therapeutic ranges. These are some of the indications with the target INR levels that you want to have. So our patient who has DVT, we should keep our therapeutic levels between 2 and 3. Some of the contraindications are seen above. We have the absolute and the relative contraindications. So if a patient has severe or active bleeding diaphysis, please do not give your Warfarin. And then if they are not going to adhere to the medication and there's not going to be any monitoring of the INR, do not give Warfarin, because we need to monitor the INR. Then we avoid it just in case we have an adolescent who's pregnant, first trimester and 2 weeks to 4 weeks before delivery. First trimester because it can cause, it affects the embryo, the growing embryo. Then in cases of allergies or intolerance to Warfarin, do not give, and in heparin-induced thrombocytopenia. However, some relative contraindications may include the uncontrolled hypertension, the severe liver diseases, and recent surgery. So while we give Warfarin, we need to also educate the attendants and the patient about the foods that they must avoid while taking Warfarin, and those are mostly vegetables, beverages like herbal teas, any vegetable oils. So I think we will need to, but our patient currently is on low molecular weight heparin. Because we were suggested, the nutrition team was supposed to try soy porridge for his nutrition, and then we need to avoid dairy products. So how do we reverse Warfarin in cases of if we are anticipating any invasive procedure, we can stop it for 5 days. However, urgently, when the patient bleeds, you can give vitamin K. Our patient bled at one point, and we administered vitamin K, and we were able to arrest the bleeding. You can also give prothrombin complex concentrates. However, you can give them together with the vitamin K, but urgently, IV vitamin K helps very fast. So the complications are still hemorrhage because you're anticoagulating, the warfarin embryopathy that we can get when a mother is taking warfarin, especially in the first trimester. There can be necrosis, osteoporosis, and Papot's syndrome. So these are some of the things we can do in order to prevent thrombosis in congenital heart disease patients like our patient. So we give long-term management of the children on anticoagulants, like they should keep on anticoagulants, especially the children who have undergone surgeries that might be predisposed. Then primarily we should prevent the thrombosis, especially in children with arrhythmias, acquired heart diseases, and those who have undergone any cardiac catheterization. We can also anticoagulate all children with prosthetic valves before they undergo open surgery. When they're going to undergo the cardiopulmonary bypass, we anticoagulate, and then treatment of heparin resistance in children with congenital heart diseases. Thank you.